طيب، بسم الله الرحمن الرحيم. ومواصلة في السلسلة بتاعت المحاضرات. الليلة نتشرف عندنا دكتور محمد الطاهر، محمد عمر الطاهر. دكتور محمد الطاهر is a senior consultant psychiatrist and a clinical lead for learning disability psychiatric team at Hamad Medical Center. He has worked as a consultant psychiatrist in the UK before joining Hamad Medical Center Corporation in 2018. He is a fellow for the Royal College for Psychiatrists and previous chair of Faculty of Intellectual Disability Division in Wales. He's a honorary School of involved in medical education, curriculum development, and student attitude and research. Recently افتكر he had a very prominent paper كانت تتكلم عن في الستدي on autism spectrum disorder. ممكن بعدين نشاركها مع الجميع ان شاء الله. فالليله نتشرف يكون معنا دكتور محمد علي. تفضل دكتور محمد.
شكرا جزيلا دكتور ياسر, and thank you very much for the organization for this hard work and time consuming. Assalamu alaikum, all my colleagues. I know that there are very senior people here as well as some of the trainees. The main reason for this kind of introduction to intellectual disability is often to answer the question why in psychiatry we're having this kind of subspecialty. And I put as well with it some sort of kind of a subtitle, history of care, present patterns and future plans as well, just to kind of highlight the fact that development of intellectual disability has very depth history, and probably if we reflect on some of the history, even if we focus on certain parts of the world, we might be able to learn a lot and shape our future as well. So the main objectives for the learning objective for the day are to kind of have an understanding of the concept of intellectual disability and the terminology in this field. I know that it's minefield of many terms being used in this area. And to learn a little bit about the history, as I said, and some sort of understanding of the service provisions and the problems with it and the challenges, and then understanding why we're coming from in terms of health needs and how the society organizes the care for people with intellectual disability. And maybe also we can reflect on some factors that influences the service provision in psychiatry of intellectual disability. I know kind of presenting in Zoom can be a challenge, but I'm quite happy to have any question at any time, so you don't have to wait till the end. Probably I'm not be able to see any comments because I'm just kind of opening the screen in front of me of the presentation. But if there are posts, so Yasser can pick them and share them as well during the talk. I'm hoping to finish, well, maybe before kind of the 1 hour, but and allow some time for discussion later on. But if we could send it more, then hopefully that would be just a reflection of the discussion. So the terminology, you probably have heard a lot. If I ask everyone, or maybe anyone, can tell us what terminology have heard about this kind of group of people. Who are they? What do they call? Or any terms that have they, just fair them. Anyone?
Mentally retarded.
Mentally retarded. Any other trainees? Any names that you heard of anywhere? Even if you want to call them in Arabic, I don't mind. You heard of anything to call them?
متخلفين, ودي كلمة شينة.
شينة, نعم, okay, yeah. There's much more actually. كلمات شينة أكثر كمان في العربي, by the way, to describe these people. Any other?
Patients with special needs.
Patients with special needs, okay.
Learning disability.
Learning disability, okay, yes. Any other?
Intellectual disability.
Intellectual disability, okay.
ممكن حاجات قديمة زمان كان الناس بيقولوا
Yes.
عبيط
Yes. Okay.
عبيط
Yeah.
وأهبل.
You heard of idiocy?
عبيط
We call them
أهبل
idiot. They call them
idiot,
subnormality being described.
imbecile.
Sorry. Oh dear, it happened. Yeah, so subnormality, retardation, yes, learning disability, learning difficulties. You hear about the word learning difficulties a lot. Intellectual disability. Yeah, there are many, many terms which are being used, whether in the past or even currently in some parts of the world, they're still kind of using them. But the main kind of message around the issue of terminology is that people are trying to kind of avoid terminology that is much more derogatory to describe this population. But if you look at how you define this population, you probably find there is a lot of overlap between certain terms, especially those which are used in the classification system. Although we're going to cover a separate lecture for classification of intellectual disability, but in general, if we're talking about any of these terms, we need to understand the definition of that term. So what do we mean by the term learning difficulty? What do we mean by the term learning disability? What do we mean by intellectual disability? That has to be very clear. But before that, I just kind of wanted to raise another three concepts which are very strongly related to this, which is impairment, disability, and handicap. Can anyone just say in just few words, what is the difference between impairment, disability, and handicap? Any of the trainees, please? I call you the trainees, but anyone who is attending, I'm not kind of sure it's the trainees, but
impairment ممكن تتكلم عن a deviation from a normal optimum function.
okay. What about the disability?
Causing a problem with the ability to cause a function, not يعني.
So the loss of function will lead to a person become disabled. And what about handicap?
That's the description of the person himself without referring to the disability.
No, it is actually related to disability, but it is socially and environmentally determined. So what we're saying kind of like impairment is the loss or abnormality of a psychological, physiological, or anatomical structure or function. So someone had a fracture, they lose, or they kind of the function of that part of the body, which has become fractured. So the loss of function is an impairment. So it has an impairment, yeah, of functioning. But then the disability is the consequent limitations of the activity or the ability. So the person who had a fracture in their leg, they become unable to walk, and therefore they become disabled. They have to use a wheelchair to be able to move. Yeah. So the disability is a consequence of impairment. Yeah. But then when we come to handicap, it is personal and social disadvantage resulting from the impairment or the disability. So it is socially determined and environmentally determined. So the person who is using the wheelchair, if the society does not put a run everywhere, for example, for them to access work or to access hospital, they become handicapped. Although they have tried to kind of, or they have overcome their disability, but they still become completely disadvantaged because of the way the society has not organized for them a ramp to be able to access work or access hospital. So these are the three words that kind of usually dictate where we go with the definitions of this population. So the population of people who has the disorders of intellectual development, as in the ICD-11, the description in the ICD-11 is that it's a group of etiologically diverse conditions originating during the developmental period. That's very crucial because many of the disorders of intellectual functioning that can happen later on after the developmental period would not be considered as intellectual disability. It has to happen during the developmental period. And the second important kind of criteria is that it has to be, there is a significant impairment of intellectual functioning. So we see the impairment in the intellectual functioning is the key and has to happen during the developmental period. It also has to be associated, which is the third criteria, with an impairment in adaptive functioning. And those impairment in intellectual functioning and adaptive functioning, which happen during developmental period, they usually kind of approximate them as to a level of 2 standard deviations below the mean of any kind of an assessment that measures whether the intellectual ability or even the adaptive functioning in sort of an standardized test. Why standardized test? Because you are actually trying to identify a population here. We're not identifying just a diagnostic. We are identifying a population according to a distribution of their functioning within the population. So if you use, for example, a Wechsler scale, as you see in this slide, if you use a Wechsler scale and measure the IQ of the population, you will have a normal distribution curve of the IQ scores. And with the mean of 100, then and a standard deviation of 15, you will have 95% of the population will lie within the mean plus or minus 2 standard deviations of the mean. Yeah. So you will have 95% of the population lie between the score of 70 and 130. So the cutoff point of 70, then below it will be 2.5% of the population, and above the 130 will be 2.5% of the population. So usually the IQ score of below 70 is an indicative of an impairment in intellectual functioning. And this is where the cutoff point of 70 comes from. And in the previous classifications, for example, of mental retardation, you find that the mild, moderate, severe is all based on scores of the IQ on Wechsler scales or on a standardized scale. And the social functioning also seem to follow the same. The social and adaptive functioning generally tend to kind of go along the same line of normal distribution. So people with intellectual disability would also have the same kind of problems with the impairment in intellectual functioning. And therefore, where the people with intellectual disability fall within the population is those people with below 70 with impairment in intellectual functioning and impairment in adaptive and social skills, and there will be 2.5% of any population anywhere in the world, roughly. Obviously, there are some sorts of certain issues with the IQ measures themselves, which we'll have some discussion about them in another lecture when we come to talk about classification. Okay, this is general about how to identify these people with intellectual disability, but where do these people come from? Even before these measures, where would they? Did they live anywhere in the society? So probably if you go back to very, very, very early ages of hunting, they call them, there are people who would not be able to go by themselves to hunt. So they will stay behind, and then some other people who are much able, they will go and hunt for them and bring them food. But then the history talks about kind of many societies' beliefs dictate how these people were treated. Some people may have looked at these children as devil children, and some of them may have also looked at them as holy children or very precious. But some societies have actually put some children with disability to death, and that has been well documented in the history. And some of them may have survived, whether just because of they managed to have someone to look after them, some did not. But then if you look at how then the society moved from just being a hunting kind of, from the hunting ages to when they start to claim land ownership, then it becomes clearly also there are people who will not be able to look after their lands. And those people will then kind of needed societies to look after them and look after their lands. And King Edward in 1325 wrote the first kind of what do you call it, act to support the idiots into some sort of survival law, what you call it. So they trying to kind of accommodate those people into the society in a way that they would be looked after, and their property would be also supported by other people. And then came what's called the poor law. But the poor law is kind of when the society started to move to like urban dwelling, the people started to recognize people who either will not be able to work, or they are not working, or they just kind of not employed anywhere. Obviously, that time was just working patterns, and some people who would kind of just engage in criminal behaviors, and people who will be recognized as what they call them at that time mad. So they started to develop places for these people to segregate them from the rest of the society into either workhouses or prison or mad houses. So you can, just from the words, you can recognize which kind of people would be kind of taken into each type of these kind of placements. But then it came in, this is kind of a picture of, from, I think it's from Yugoslavia. So kind of one of the largest kind of institutions at that time of what you call them asylums, where they segregated those people who needed to be kept away. It's, not mainly kind of like in prison, or but in the mad houses or workhouses. But then the scenes of these kind of placements, if you see the picture, it looks nice and looks nice buildings, but inside those places, there were descriptions of very poor kind of cruelty, poor kind of care provisions, including misery and neglect, and not people being treated very well. Can anyone, or does anyone know about the wild boy of Aveyron? That's kind of picture on the side. The wild boy of Aveyron was found in the jungles in France in the early 18th century, and he was found to be living with the animals in the jungle, a very kind of primitive life. He does not have any speech, but he was surviving. He will jump on the trees everywhere, and he would just kind of eat like the animals, kind of, and living really like an animal. So he was picked up and then taken to Paris, and Itard tried to educate this young boy to teach him how to speak. And in fact, some of the later kind of talking about this boy and the writing about it suggests that he may have had autism. But then that was kind of the first attempt to kind of to educate a boy, which has been kind of reported in literature. And then after that, they started to develop what's called the schools for idiots, or school of idiots. It started to look at how children like the wild boy of Aveyron can be existing in the community, in the society, and can be picked up and educated in what's called the special provisions of education. And some people started also arguing for much more humane methods of treating these people and supporting them. And hence, then the societies in Europe in general moved into trying to kind of develop what they call them schools for idiots. And they developed a number of schools in the 18th century. In the 19th century, they were kind of like I think one of the main kind of schools were these 4 schools, which is Bath, Highgate Asylum, Darren Training School, and Royal Air School. These are kind of the main kind of provisions of the schools for children with intellectual disability. And then obviously, the more the society became organized, they started looking at some sort of laws that govern these asylums. And then it came in what's called the Idiocy Act, which is kind of laid down some sort of procedures for admission and discharges, or to these kind of placements, and registration and inspection for these placements, so that some governance are being put in place there to ensure that it's not being places for some cruel treatment or something like that. So placements were very deficient. You can imagine these were kind of like the placements which were available in the whole of UK at that time was 1,881 kind of placements. And then one of the other kind of factors in the history which has influenced significantly and changed the shape of the provisions of services in general in Europe was the Industrial Revolution, where the society started to look at more work and education. So people who would not be able to kind of have further education, they have to be trained so that they become workers, and you have to be productive to be living in the society. So those who will not be able to kind of learn or educate, they need to have some sort of certain places to go to, which is then the schools were empowered to kind of ascertain those children who were not kind of educable, as they call them. This was also kind of again was influenced significantly by at the beginning of the 20th century, where the genetics started to kind of talk about the throwbacks to primitive societies and the panic that came through with what you call the eugenic move. The picture there was for Langdon Down, and although he is the one who discovered the Down syndrome and is named on his name, his view at that time was actually those children with the Down syndrome were actually thrown back to the Mongols societies. So it was quite, in fact, a nasty kind of viewpoint, but unfortunately, he still kind of have the Down syndrome being named on his work. And so in the UK, then it continued again the thinking about how to provide for these people with or children, especially with who didn't have were non-educable, as they call them. So it came in sort of what you call a paper about or the Royal Commission about what's called the feeble-minded people. So those children who have been identified as defective should be identified and segregated for their own protection and happiness. This is according to the view, but obviously they were segregated away from the society. Unfortunately, again, that was also influenced by the Mental Deficiency Act, which came in 1913. And this act actually classified those people with, as idiots, imbecile, feeble-minded, and moral defective. And you can see the moral defective, obviously, those were the one with the personality disorders who end up kind of having criminal offending, and they'll be segregated separately. But the other three, the idiot, imbecile, and feeble-minded, were those people with falling within the intellectual disability. So what this kind of law allowed people to do is to certify those with either of those kind of identifiable problems, and then they will be admitted to the whatever the care home at that time, which is the asylum houses, and they will have a certificate for 5 years and be renewed every 5 years. So later on, they allowed for, rather than the admission under the Act, they allowed also for voluntary admission, and they identified those if parents, for example, wanted to bring their children in, they don't want to look after them anymore, they can bring them and they be admitted, or if they are found neglected or abandoned in the streets, or if they found them as what you call they are in moral danger, or being treated cruelly by someone, or if they are guilty of criminal offenses. So all these kind of people can be taken and put into those kind of asylum places. Now, those asylum places were mainly looked after by the local authorities, were not they were kind of like for the young children, they will be kind of for in education, in placements that they can educate them, or if there are others, they'll be there for placements of training, and if they can be trained to work, they may be able to kind of get them into jobs, but if not, they will remain into those asylums. And unfortunately, again, some of the cruel enough treatment which has been in those asylums was that the females were usually being sterilized. And in fact, sterilization for women with intellectual disability has continued in Europe up till 1947. I'll leave you later on to think about those things. But the healthcare was kind of provided within those kind of asylums only. And those asylums were later on changed when the National Health Service came through in 1948, where they changed all those local authorities' placement into institutions, into hospitals. And they became under the responsibility of what is called the medical superintendent. So the medical superintendent took over those asylum places, and all those people who were there then were looked after by the medical profession from that onwards. That's from 1948 onwards. So the local authority sort of have shifted a little bit. They become a little bit sideways, and then the genetic move has become a little bit fading, and the people started to kind of looking after the health of those people who is mentally ill or mentally handicapped, and hence in 1959 came the Mental Health Act in England. The Mental Health Act in 1959 identified two groups of people: those with mental ill, or those with handicap or mental abnormality, and those with mental abnormalities, either with mental abnormality or severe mental abnormality. And they made some different provisions for the mental abnormal or the severely mental abnormal. But then it also pushed the local authorities to develop some residential placements and homes, so that some of those people who were in those asylums can be actually moved to those places. So those with severe mental abnormalities who may not need to be in hospital can be discharged out to the local authorities' care. But then what happens is, I will show you some of the pictures later on of this is this picture of the Cardiff workhouse. This is the workhouse which was then taken over by the health and became the Cardiff hospital for learning disability. Yeah. What happened in 1970? A committee of inquiry came into Cardiff Hospital to visit the hospital because of some complaints about how the people has been treated in that hospital. And they, in fact, found this the patients who were there in the hospital treated quite badly. They did not have enough clothes. It was winter time. They did not have blankets. Treatment in the wards were quite cruel and bad. People were showered kind of with a hose, kind of on the corridors, and it was quite bad. So the committee actually decided to camp inside the hospital and refused to leave the hospital till the situation has changed. And this was marked in the history by what's called the Ely Hospital scandals. And in fact, straight away after that, a full investigation into all the asylum hospitals started. And from that scandal, then a new service provision was planned for the mentally handicapped people. Then an Education Act was also put in place at the same time in 1970. So the white paper, which was published straight away by the government after that, is that they wanted the services that provide much more kind of prevention, comprehensive assessment, coordination of services, education and training and occupation for people, and residential accommodation according to needs, and again, medical and nursing services according to the needs. So these were kind of they're saying, okay, well, let us kind of do something better for these people rather than just keeping them into those kind of asylum hospitals. And the recommendation was that all the hospitals, all these large hospitals, which you call them institutions, in UK should be run down to close, and to develop social services provisions for them, including daycare, residential care, and to do something about these old hospitals, and to develop some sort of multidisciplinary approach to looking after these people with intellectual disability. Some of the, during that period as well, some of the ideas that's been thrown out as well in the whole world has been quite influential in shaping up the kind of move of how to treat these people and how to provide service for them. And one of them is the normalization theory, or the what we call social valorization theory, which came by from Wolfensberger, who is a Swedish guy, who a psychiatrist who moved to US, and he wrote about how these people should be treated as normal people, and this has kind of significantly influenced the provision of planning services for them. Equally, there was a guy, Greg O'Brien from UK. He also talked a lot about, he was also a social psychologist, and he talked a lot about how services should accomplish certain criteria to provide service for people with intellectual disabilities. And the principles which were laid down by both of those movements were that the people can have the opportunity to leave home. So if they don't want to be as adults to stay at home, they can leave to another place. They have the right to move to or to live in a mixed sex environment. So they have the right to marry. They have the right to kind of have whatever in the society there as a boyfriend, girlfriend, or to have proper segregation for their home, work, and leisure, and to be better treated as individuals, and to receive additional help when they need. So these are kind of the principles that guided the services or the service provisions in the 80s in the UK. And the service accomplishment, which was written by Greg O'Brien, we're talking mainly about those people with intellectual disability should have community presence, should be there as part of the community. They should have choices in their life, wherever they want to live, whatever they want to eat, whatever they want to do, dress. They should have choices in their life. They should be developed to their full competence, so they should be allowed to work or train or go for education to the level that they'll be able to develop their competence. And they also should be treated with respect and should have ability to form relationships or choose their relationships, whether within their family or out their family. They should have friends. They should have a relationship with anyone they want. Hensel Hospital, I put the picture here because this is the place which I started my training in intellectual disability. Hensel was one of the asylum hospitals which was existing at the time when I joined my training in the UK, and I did my SHO training, and then while I was there, I came to do my specialist training when the hospital was closed. It's a very beautiful castle with streams around, 4 hectares of land, and we had probably around 10, there were 10 wards around this castle in the hospital. The hospital was closed in 2004 when we managed to move the last patient from the hospital, and it was sold to a cinema producing company, and the rest of the land was converted into large kind of resort, hotel, and spa, and a rugby field for training of the international teams, and blah blah blah, lots of things. So you can see they have used the whole kind of the asylums into a different way of use, while all the people has actually moved back to live in the community. But that also came with a lot of kind of challenges. I remember at the time when we were closing the hospitals and moving some people outside, there was a lot of difficulties with moving some people, with especially the those who has significant behavior problems, and we call them people with challenging behavior. So we needed to develop some sort of specialist support services for those, especially who are the most challenging. But there was also problems with choosing the ordinary living patterns and their work. So there was a lot of kind of development for workplaces, for daycares and education placements, but it was quite challenging. So in the UK, don't worry about this slide too much, but it's just as I was saying, at that time, there was a lot of kind of people who were moving out from the institutions into the community. So that has led to some improvement in the community service provision for those people, with some funding become available, with some more work between health and social care to provide better services for those things. And they started kind of then, the more people in the community, the more change in the demographics and patterns of living become apparent. There's some kind of literature about some of the work that have been done around the community provisions and what is the impact of the what we call congregate living and supported accommodations versus kind of independent living patterns of life. So has it improved? Has there been evidence for improvement of an improved outcome? Yeah, I mean, the literature suggests that there has been improvement in the pattern of health provisions. So there's better health provision for people when they move to the community. There's much more improvement around communication. So people started to become much more communicative, become much more engaging in the society in general. There is also development of domestic skills. But there also then people started to face much more challenging situations, and therefore they become much more behavior disturbed, and then we see much more increase in challenging behavior. Eric Emerson is one of the social psychologists who study a lot kind of the publish many books on psychiatry, psychology of intellectual disability. He said that there has been much poorer quality of life for people with intellectual disability than the general population, which I think the evidence of it is usually collected regularly through reports that he published from the Institute of Psychiatry regularly. So what challenging behavior, we talk about challenging behavior in a separate lecture, but just to say to you what it means kind of by challenging behavior is the fact that some people who were kept in the past, for example, in certain care systems, they may not be challenging in that setting, but you take them into the community, the pressures, the stress, the environment, the interaction within the living environment or the outside environment can cause a lot of behavioral problems and challenging behaviors, including offending behaviors within people with intellectual disability. And those people who has much more challenging behaviors, they have much more less kind of favorable outcomes. So it become a problem for certain, provisions. So people were saying we need to build the hospital back to take these people who are very challenging. But then if we do that, they will return back to the asylum patterns of care, which is kind of the society has moved from it significantly. I must say, kind of, although we are studying this example of the Europe and the UK as kind of as an example, but I have seen patterns similar to this over the history in different parts of the world. And in fact, we did some search around what's happening in Africa in certain countries. There is a book which is we wrote a chapter of myself, Asia, and Dr. Mo from Nigeria. Both he's now in UK. We wrote a chapter about Africa in a book which is called Intellectual Disability Across Cultures. And when we looked at the patterns in 13 countries, because we used Sudan, South Sudan, Nigeria, South Africa, some other countries as kind of, we pick them as examples, we see similar kind of patterns of increasing challenging behavior at times, the provisions, the difficulties with the education system, the care, and I think it's probably the book should come out by the end of this year, and I think it would be a very good read for everyone who is interested in this field. What happened in the UK, then people started to have much more of private sector solutions. And to be honest, this is one of the surprising things, which to me as well, when I came here to Doha 5 years ago, nearly 5 years now, when there was kind of one of the provisions for children with intellectual disability, which is called Shafallah Center, if some of you know. And there were some provisions within the mainstream for what's called supported education. And there were a few private schools as well in providing for children with intellectual disability. What I have seen in the 5 years, almost tripling or maybe more than tripling of the number of private sector provisions for people with intellectual disability, especially others, in Qatar, in the very small kind of society of this place. So this seemed to be kind of like the pattern. It's become like a market now for providing for this kind of population in terms of different kind of provisions, whether education or other types of provision. But there are also problems with kind of with providing services for these people or care, which is well identified by local authorities in their placements. Usually keeping staff or recruiting staff for these provisions of care is very difficult, and there is a very high turnover of staff looking after these people. They don't, either because they are not paid well or because they don't like it. And there are always issues of training and getting skills around how to manage those people, especially with challenging behavior. And the issue with the day service provisions as well. There is no clear kind of goal sets and plans for how to provide the daycare. So even like in my current kind of, as I said, placement here, I see many people providing day service provision, day service for people with intellectual disabilities and autism, and they have different goals and different setups, and there's usually kind of a lot of complaints from families about what they are providing, whether it meets the needs of these others or not. And then it become every age or every era had its own debates and challenges. So there is kind of become a new, what's called moral panic, which is kind of how should we deal with these kind of people, especially the offenders? How do we look after those people with profound or multiple handicaps? Should we still kind of keep them in hospital? Should we provide for them in their own homes? Should we segregate them again? And those with challenging behavior, and many kind of challenges are kind of facing planners for services. I'm sure you would say this is a very beautiful kind of place there, with many cars here, which reflects kind of like a very busy place. This is the Winterbourne, and some of you may know it's Winterbourne, but it was one of the private hospitals for others with autism and challenging behavior, severe challenging behavior. Unfortunately, the Winterbourne had one of the largest scandals in the history as well in the last few years, where an undercover journalist, investigative journalist from the BBC, went in and worked as a care worker in this place and videoed very cruel treatment for those others with autism in this place, which led to a panorama program, and immediately the hospital was close and full investigation was carried out. And an winterborn then new policies has been initiated across UK for uh, for closing these kind of again private placements for people with autism and intellectual disabilities. Now, this is just to say that even though we may provide care and services for these people, but abuse can happen everywhere, even in the very high private, highly funded placements such as the Winterbourne. So these people, unfortunately, are vulnerable to be abused. Abuse can happen to them across many, many different services. Okay, so this is kind of about the history, but what kind of shapes kind of usually the needs of these people? So why then they needed kind of psychiatric care on top of the kind of what we're trying to provide as care? And we know that they have much higher health needs than the general population by definition. Many of those people, regardless of the causes of their intellectual disability, whether it's genetic or any other cause, it also be associated with some health issues. And we know that there are certain kind of diseases or are highly prevalent in this population, such as epilepsy, sensory problems, for example, hearing impairment, visual impairments, mobility problems is very high. We know that mental health problems are much high frequency, and also behavior problems occur at much high frequency as well in this population. So we have many reasons that we think that the people with intellectual disability would need psychiatric care, or they would suffer from psychiatric conditions, and those can be divided into biological, psychological, or social. And I'm sure you can list a lot of kind of biological factors, but the main fact is that they have some dysfunctional brain for whatever the reason, or they may have particular syndromes from the genetic kind of origin. And epilepsy, as I said, is very common in this population, the physical disability, and most of them end up with having loads of medications which we require, will may cause also side effects, with all these biological causes could be considered as causative. But they also have a lot of psychological problems. They may be aware of their limitations, or even if not aware of their limitation itself might affect their ability to cope. They usually experience a lot of failures. They are subject to many traumatic experiences in their life. They have limitations in their skills, and therefore they may not be able to kind of cope with any pressures or stress. And they also have many temperaments, which can also make them much more subject to develop kind of behavior problems. They may also have behavior phenotypes of genetic disorders, which can be also quite significant. Social perspective, they have a lot of problems with the relationship. They do not choose who they relate to, even in terms of carers. And they also have problems with having friends and relationships with the other sex, maybe. And they have inconsistent care. This is always happening. So sometimes they may be in one place, and they might move to another place, or they may have to be subject to different kind of care provisions without their decision. They also may have multiple caregivers. Each one of them might have different views. They may have different ways of treating them. They have limited access to resources. They may not have money. They may not have even the ability to access certain resources because of limitations, because they don't work, they don't earn money. There may be problems with compliance in general, whether compliance with care or compliance with treatments or any kind of disease or ill health that they need treatment for. And there may also be problems with the unreasonable expectations of them that they can comply or they can do certain things which can be quite pressure for them. So all these biological, psychological, and social factors can be quite significant in determining the comorbid mental health, behavior problems, and physical health problems in this population. So, in summary, this is just a talk to introduce the subject of intellectual disability. I hope I've been able to kind of show you some of the history of the care has been developing for these people across societies. I'm sure in our own society, whether we look at it in the Middle East or in the kind of Islamic world or even specifically in Sudan, we can look at how society have been trying to organize care around these people, but although they are very vulnerable population, they may also be subject to a lot of cruelty while we're trying to kind of provide service for them. There are different societies' views about who should be leading the care for these people. Is it the social services, or is it the local authorities, or is it health? And if it is health, then there are a lot of issues with does health needs dictate that these people should be, locked in hospitals or should be providing health for them while they're at home, with their families or in the community. And there are a wide range of kind of health provision that could be provided for these people. In terms of the psychiatry of intellectual disability, is becoming an increasingly recognized specialty due to the need for these people for a specific psychiatric health and interventions to treat those mental disorders, comorbid mental disorders, as well as the challenging behavior. In general, in any psychiatric services, there will be about 40% of the intake of any psychiatric intellectual disability services for people with challenging behaviors, which means kind of that this is quite a significant bulk of their service, which need a lot of work in terms of behavior analysis and developing interventions based on behavior theories as well as kind of some medical interventions. So, as I said, I'm hoping I've just introduced to you the intellectual disability as a concept, as a service and a bit of a history, and hoping that in the next few lectures coming, we'll be addressing a little bit kind of, or delving deeper into the kind of intellectual disability to have a better understanding of the classification, the etiology, then go into epidemiology and comorbid conditions, the other neurodevelopmental disorders, and then how we can do assessments and develop interventions and preventions. Thank you very much for listening, and happy to leave the rest for the discussion.
شكرا جزيلا دكتور محمد على المحاضرة القيمة جدا جدا الليلة. واحنا هسه نشوف لو في زول عنده اي سؤال اتفضل طوالي. حاليا في تعليقات. شكرا على المحاضرة من دكتور ياسين الجدال، وشكرا على المحاضرة من إيمان عمر وهيفاء. لكن إذا في زول عنده أي سؤال تفضل.
السلام عليكم دكتور.
عليكم السلام ورحمة الله وبركاته.
كيف أخبارك؟ شكرا لك كثير يا على المحاضرة القيمة. you led the platform يعني for أي من المحاضرات بإذن الله في learning disability أو intellectual disability. فشكرا لك كثير. لكن يعني دي ذاته كلنا يمكن مدخل لأنه الناس تفكر في إنه زي ما أنت قلت كيف الموقف في السودان. فالchallenges is even يعني more في السودان للكيررز. طبعا mainly ما في أي input من authorities. It's very challenging for both the families والبروفيشنال. فالعيب ما بقول عيب، لكن it's very يعني rewarding for us to as professional practicing في السبيشالتي في السودان. يعني أنا I have no doubt يعني it's more rewarding to provide our own people there. وبتلقى كثير من الأسر يعني بيدعموا كثير، ولكن حتى ال care provided يبقى مثلا هو معظم السنترز هناك especially led by families. فيعني families who have a child or a person with intellectual disability, but they take the most of the burden, I can say the whole burden upon families. It's good for trainees إنهم to think about the difference between developed countries and our own country. إن شاء الله يعود السودان يعني يكون إن شاء الله more يعني people in Sudan they deserve better يعني. لكن it's good for them. أنا كنت معلش أخذت لي فترة ما تابعت المحاضرة في الجزء الأول، فما عرفت بالأسسمنت، لكن it's good to lay the platform إنهم يفكروا about the ways of يعني evaluation of an intellectual disability ده، لأنه بيكون مدخل لمحاضرات تكمل إن شاء الله. شكرا لك كثير دكتور محمد، يعني ربنا يحفظك ويوفر الباقيين كلكم.
Shukran. Thank you, Aisha. Thank you for the words and the support. I'm sure we're looking forward as well to you participating in the coming lectures. As you said, we're just kind of setting the scene for that. For the trainees, yes, absolutely right. What we think is important for all the trainees is to, at least through this course, to have a good understanding of what's intellectual disability, what are the comorbid conditions that they see in people with intellectual disability, because they come to the clinics everywhere. We will be working, you will see people with intellectual disability coming for different reasons, whether because of comorbid mental health or because of the challenging behaviors. And rather than just medicating, we will be talking about later on in the assessment, how do we do really good assessments, how do we address issues of communication when we're addressing this special population, how do we work with families, how do we ensure that if these people are treated, how do you approach medication, how do you approach kind of monitoring. All those things will be talked about, inshallah, in the next few lectures with Dr. Aisha and the others who will be part of this group to deliver these talks. But we're just kind of setting the scene for those, as Aisha said. Any other? Dr. Yasser mentioned earlier at the beginning of the talk about the paper on the genomics of autism. In fact, I just kind of presented actually last week this paper in our CME. So if people want it, we can give it at again as another topic lecture, but maybe at another time in the future. But
I'll be happy to distribute it with them.
It will be a little bit kind of like a bit of a high-tech, high-level, genomic kind of talk, not in the kind of the base of the intellectual disability. Very good.
If no further question, I think احنا ممكن ننهي المحاضرة، وإن شاء الله أفتكر أنا بتواصل معاك بعدين